with the MACE or with the morbidity and mortality of those patients. The second domain, MVO or microvascular obstruction, that sometimes happen even though that the patient is being reperfused, but the capillary bed now is dysfunctional and there is no flow in the capillary bed. Literature have showed, many research now have showed that the relation between the MVO and the MACE or the major cardiac events that could happen. So far, it's being discussed in the literature whether there is MVO or there is no MVO. But recently now research is targeting the relation between the amount of the MVO, not only whether it's present or absent, but now measuring the amount of the MVO is correlating with the morbidity and mortality of those patients. Early enhancement or late enhancement. So we have what's so-called early MVO and we have what's so-called late MVO. Early enhancement is usually 1-2 minutes after giving the contrast. Late enhancement is above or after 5 minutes acquisition. And usually the areas of MVO during the early enhancement are larger than the late enhancement. This is because that the rate of the diffusion and the dynamic of the contrast in those areas is happening or taking place by diffusion, not by the arterial supply. Now research is being discussing whether to measure the MVO in the early enhancement or the late enhancement, and the discussion whether which is correlating more with the morbidity and the mortality. So far, it's the early enhancement that shows the real and the accurate size of the MVO rather than the late or the LMVO as being discussed in literature. Edema, which is the area at risk. Edema is very important to measure. There are many techniques to measure the edema, but the traditional so far is the turbo inversion, T2 mapping, or the contrast enhanced CC or the steady state, doing the short axis steady state cines after giving the contrast. But so far the term or the turbo inversion recoveries is the gold standard of measuring edemas. At the beginning it was very subjective to see the edema, the high signals in the affected territory. Later on it was compared to the skeletal muscle, but now many vendors put the coils underneath the patients, which gives a lot of artifacts. Now softwares measure the amount of the edema in the affected territory in relation to the remote unaffected myocardium. So if the average signal exceeds the average signal in the unaffected territory plus 2 of the standard deviation, this would reflect that this is in edema, and the software will take it in consideration. For example, in this case, in the affected territory, which is the LAD, the edema is 72 average signal, and the unaffected LCX territory 40 plus 2 standard deviations, which is 10, so it's 50. So this reflects that this is going to be included in the software when you are measuring the area at risk or the edema area. Sometimes it gets very complicated. For example, in this case, the patient had 2 culprit lesions in the LAD and in the RCA. And this shows the importance of using softwares, because otherwise the whole territory or the LAD and the RCA are showing edema, and it was very difficult to measure the area at risk in this patient. But now softwares would measure the edema according to the 17 segments, so it would tell you where exactly the area at risk. intramyocardial hemorrhage is now literature, or now the research is saying that it's correlating with the morbidity and mortality of the patients more than the MVOs, more than the microvascular obstruction. And this reflects how important it is to detect and see areas of intramyocardial hemorrhage in those patients, because this is going to be an important indicator for the prognosis of those patients. The sequences used to indicate or to see the intramyocardial hemorrhage would be either the STAIR, which is so far and term are the gold standard so far. T2 star is coming, and T2 star now, literature is discussing the role of the T2 star in those patients. Using the term or using the STAIR, as you may see here, there is a large area of edema, there is a large area at risk, and the central core would show some areas of hypointensity. I'm not sure, it's just a thin line in the middle of the area of the edema. This is an example of the T2 star. For example, those two cases, in the T2 star maps, there was no hemorrhage, but in this example here on the right side panel, there is this blue line, which is considered to be hemorrhage in this area of MVO. So it's literature still comparing the role of the T2 star and the term, but so far the term is the gold standard of measuring hemorrhage. And this is another example for another patient who had an LED infarction, large MVO, and this is the term in the middle, and on the right side was the T2 sequences. And as you may see, it is expected that we would see high signal intensity in the edema area, but the T2 map is showing a signal of 50, which is contradicting edema, but this is because of the presence of hemorrhage. I'm not sure if the term here, could you see like a thin line of hypointensity in the middle of the edema area or in the middle of the area of at risk? This explains why the T2 maps are coming 50 and 52, although that visually we could see edema areas. Infarct size, whether it's subendocardial or whether it is transmural, that's very important to mention. Whether it's the how big the territory is being affected. Is it mid? Is it apical? Is it basal to apical? So far, assessment is inversion recovery or the PSIR in order to assess the infarction size. Now softwares, if you include the endocontour and the epicontour, and then you adjust a reference of a normal myocardium, and here at the bottom, I'm not sure, could you see my cursor? So this has to be adjusted, that the main +5 of standard deviation of the reference, so that the software will pick all areas of enhancement as the infarction size. As you may see in this example, the late enhancement 52 grams, which is around 40% of the myocardium. This is the size of the infarction, and of course the bigger the size, the worse the prognosis of this case. So what we do is that we draw the endocontour, epicontour, we set an area as a reference, normal myocardium, and then an area as a reference for the enhancement, so that the software will pick up all the areas that showing late enhancement. Salvage myocardium, or the area at risk, is the targeted that to measure after a myocardial infarction to see how much is being salvaged of this myocardium, how far is the successful PCI. And this is the area that needed to be saved before turning into necrosis. Similar to what we did in the infarction size, we could do the same in edema, but rather than using